Good evening. My name is Kelly Crow, and I'm a member of the University Hospitals Marketing and Communications team. On behalf of the entire University Hospitals family, thank you for joining us for our webinar on innovation in orthopedic surgery in 2021, what's new and what's proven. From robotic surgery to biological treatments for osteoarthritis, this presentation will review both surgical and non-surgical topics and discuss evidence-based medicine and the research supporting, or lack thereof, recent advancements. A couple housekeeping notes before we begin. In this platform, all attendees are muted. While you won't be able to ask questions through your microphone, please note the Q&A function at the bottom of your screen. If you have a question that is not addressed in the presentation, please submit your question through the Q&A feature, and our presenter will address questions at the end of his presentation. Also, this evening's webinar is being recorded and will be available for viewing on demand in the near future. It will be posted on our website, and as an attendee of today's session, you will receive an email with that link. It is now my pleasure to introduce our presenter. Dr. Brett McCoy is a board-certified orthopedic surgeon with a subspecialty certification in sports medicine. His surgical practice includes arthroscopy of the shoulder and knee, total joint replacements, fracture repair, and the treatment of soft tissue injuries. From a non-operative standpoint, he cares for a range of musculoskeletal injuries from minor aches and pains to fractures and arthritis. A Cleveland native, Dr. McCoy joined the University Hospitals Center for Orthopedics in 2020 after 8 years in practice, most recently serving as division head of orthopedics at Marymount Hospital. Dr. McCoy earned a bachelor's degree from Miami University and completed his medical training at the University of Cincinnati. After medical school, he completed an orthopedic surgery residency at Northwestern University, followed by a sports medicine fellowship at the Cleveland Clinic. During his training, Dr. McCoy had the rewarding opportunity to serve as assistant to the team physician for the Chicago Blackhawks, as well as the Cleveland Browns, Cavaliers, and Indians. After completion of his training, he served as the team physician for Cleveland State University, the Cleveland Monsters, the Lake Erie Captains, and 5 area high schools. He has also worked as a clinical assistant professor at Lerner College of Medicine of Case Western Reserve University. In his free time, Dr. McCoy loves to explore the outdoors with his rescue dogs. He also snowboards, plays ice hockey, and spends a lot of time with his family and friends. He's an avid reader who seeks to continue learning. It is now my great pleasure to introduce Dr. McCoy.
Thank you very much. So obviously this virtual format isn't quite as personal, a little difficult sometimes, but I'm going to do my best to go through a fairly broad topic. So the idea of innovation in orthopedic surgery is, I think most of us as clinicians field a lot of questions from patients about cutting edge technology, and some are better than others. And I think the big thing is any one of these topics can be an hour in and of itself. But I think understanding how we as physicians and scientists evaluate innovation is perhaps the most important thing to take away. But I'm going to try to run through a bunch of different topics and talk about different things, looking at contemporary techniques, what has wonderful theoretical benefit, what's proven, what's unproven, and what's on the horizon. So as was mentioned, I work for the Center of Orthopedics. This is a list of our doctors here. We have 5 different outpatient office locations, and we operate at 3 different hospitals, and there'll be some contact information at the end. Bio we already did. So one of the big things I think in medicine that we've proven in the last year is we often don't know what we don't know. And so if you look at, historically, we've done some things. So cocaine was used to treat toothaches, impotence, depression, and was actually found in Coca-Cola. Heroin was combined with aspirin and given to children as an alternative to morphine. So when we look back at things historically, we have often, later think, oh, we had so much to learn still. And we look back historically, cigarettes were given for asthma. Arsenic was used to treat syphilis. Lobotomies were a thing. Bloodletting was pretty common. But a lot of these are more historical, even more recently. So this is a metal on metal hip replacement. When I was a resident not too long ago, these were incredibly popular. So they're, advertising 60% less wear, more stable because you can get bigger head sizes. And about a third of these patients went on to have these massive reactions. And this is an MRI that shows a pseudotumor of vasculitis related to some ion debris from the cobalt chrome. And so this pretty quickly fell by the wayside. So now when you Google metal on hips, you see various things with attorneys reaching out, looking for settlements. So this is a list of some of my publications and some book chapters. There's a variety of things here, and it doesn't make me an expert on any one thing, but having conversations with people over the last year during COVID and people's opinions on, vaccinations and science, I realized that going through research and working with, an IRB, which is empowered by the FDA and the Department of Health and Human Services, that really looks at ethical analysis of studies before you start, but also having conversations about data analysis and outcomes with statisticians really helps understand what a strong and well-conducted study is versus something that's lower evidence. We also see multi-center studies, which helps us for more rare conditions, and databases and registries that help to provide large sample sizes so we can have stronger recommendations based on research. So if you look at clinical research, and this is how all innovation should start, we basically start with a good idea or a laboratory study. Some will be animal studies after that. Then we start out with small groups of people and we follow them along. Later, we need larger groups, we need comparisons, and we need long-term follow-ups for most things, particularly some of our treatments. So if you look at clinical research, the lowest possible level on the pyramid is an expert opinion. So if you come to me and I see you and I give you an opinion, that's not the best evidence, but assuming I'm well-trained and intelligent and pay attention, it's not bad. But that's an N of one. So then as we move up, a case study will be following one person. Cohort will be following a larger group of people, which is good. But randomized controlled trials, when we can have them, that's not always feasible, are the best. And so if you take, say, 1,000 patients with arthritis and you give, half of them aspirin and or ibuprofen, and you give half of them a sugar pill. And if it's double blinded, the patient doesn't know what they have, the doctor doesn't know what they have, and we follow their outcomes. And that is a good way to get strong evidence. Now, at the very top is when we review multiple randomized controlled trials. And so you can eliminate various biases. And that's sort of the gold standard, are systematic reviews and meta-analysis of other big studies. So with that, brief background in evidence-based decision-making, let's run through what's new in arthritis treatment. So patient-specific joint replacement. So this is some pretty cool technology. The picture on the left is some templating we do online with the knee replacement. And the picture on the right is an example of a guide that's manufactured specific to each patient to help positioning for a total shoulder or reverse shoulder replacement. So if we look at patient-specific implants, there are some studies to suggest that it can help a little bit with x-rays afterwards. But if you look at a lot of the higher volume surgeons, it hasn't shown a massive difference. Having said that, for complex cases, I think it can be incredibly useful. Robotic surgery. So this is becoming increasingly common. Patients are asking for it. Hospital systems are trying to get more robots. This is a fascinating technology that is something that I'm adopting in my practice and trying to do more of. And I may have a partner on this webinar that does quite a bit of them. So I have to be careful what I say here. But when we look at, for at least a knee replacement, at a 10-year follow-up, they had fairly similar results. So they're saying that based on a little bit of additional time, that they can't necessarily recommend them. But I think that there's a couple situations that both the patient-specific implants and robotic surgery is very useful. One is lower volume surgeons. If somebody isn't doing something as frequently, I think it can make a huge difference. In this study, the doctor did 1,000 with the robot, and there was 990 and 975 without. So for lower volume surgeons in complex cases, I think it's incredibly useful. This is a partial knee replacement. I've seen a couple people back in the last week. One was 5 weeks out and he's ready to go back to work. The other one walked in today 2 weeks out with no limp. And this is an operation that we should probably be doing more of. And so depending on who you talk to, maybe 20 or 30% or even higher of knee replacements could be partial knees, but it's a less forgiving operation and it's got a higher failure rate if not done correctly. And this is an operation that I think in my practice, the robot is perfect for. This is an example of a patient who has a plate down below to straighten the leg out, but has significant wear and some dysplasia of part of their femur. And you can see this divot or defect here. And this is an implant that was placed with a robot that, we templated ahead of time, and we're able to figure out the exact size because it was a very small, undersized part of the femur. And it was absolutely a very straightforward case with a great outcome that would have been difficult otherwise. I also think, while I don't do the hip replacements, establishing leg length discrepancy and to get the leg lengths just right and to put the cup in a perfect position so it won't dislocate is a wonderful indication for a robot. So I think that that's a technology that is very good and only getting better. And again, my partner that does a lot of them, Dr. Stanfield, who may be on this webinar, anybody who's interested in this technology, I would encourage seeing him because he does them very, very well. Approaches for hip replacement. So patients ask me a lot about hip replacements. The anterior hip is a big thing right now. And, I don't do hip replacements, but I certainly see plenty of people with hip arthritis. And, there are some studies that compare to a more traditional approach, either the lateral or posterior or lateral. And this is a busy slide. You don't have to look at all of it, but it basically shows that, after the first 3 months, the results are very similar. So in certain patients, they do better initially, but in some respects, this was a randomized study. People with larger abdomen will often be told they weren't candidates for the anterior hip. So a lot of the skinnier, more active patients were getting them. So there was a little bit of bias there. But I do think that outside of the first few months, we're not really seeing any significant differences long-term. This is a study, though, that does show there's a significant learning curve for anterior hip. So if a patient asks me about an anterior hip replacement, so you can see this green line at the top, there's a revision or a redo rate of over 6% for people's first 15 operations. And that goes down significantly when they get over the first 100. So versus choosing the approach, I think you want to choose someone who does the operation, does it well. And at least that's the conversation I have with people. Joint replacement materials. This is another topic of conversation for hip replacements. So standard hip replacement was a metal ball, usually made out of cobalt chrome, and basically a polyethylene or fancy plastic liner. The big advancement in the liner was cross-linking it so it doesn't wear out. So versus the implants that were placed years ago, the ones we have now last much longer. We're also using ceramic. You can either have ceramic ball and a ceramic hip or socket, or a ceramic ball with a polyethylene, a cross-link polyethylene that lasts longer socket. And these are good implants in younger people. There's a lot of different studies that compare the longevity of those, but for the sake of time, we'll skip ahead a little bit. So we're also seeing now more, traditionally a hip grows into the bone and knee replacements are cemented. So we're seeing an increased amount of press fit knee replacements. And you can see this porous surface underneath the knee that helps the bone grow into it. And so patients will sometimes ask about that. That's a newer technology for knee replacements. Well, it's been around a while. It's increasing in prevalence. And there are some studies that show a very similar 15-year survival rate. So in the cemented knees was 80% survival at 15 years. The press fit was 75%. But one of the things is the technology gets better, and the technology from 15 or 20 years ago isn't what we have on the current implants. So it's always hard to follow the longevity of some of these implants because the technology can outpace the studies. Ankle replacements along the lines of arthritis. When we compare, ankle replacements are becoming increasingly common. The traditional operation for an ankle is an arthrodesis or a fusion. Ankle replacements are showing fairly similar results at 5 years. But one of the big things with a fusion, once a joint is fused, it just tends to stay fused. And so a replaced ankle, like any moving part, will eventually wear out, and a redo could be pretty difficult. But the idea is to preserve motion around it to help prevent arthritis. So I'd say the early to midterm results are getting much better for ankle replacements, but this is something we're really going to have to follow for a lot longer because obviously an operation for somebody who's in their 50s might need to last 40 years. This x-ray shows a patient where you can see the ball is sitting up above the socket here, should be down centered in the socket of the glenoid. This is something called rotator cuff arthropathy. So somebody with a long-standing large rotator cuff tear, the ball migrates north a little bit out of the socket and they get a rapid form of arthritis. And so somebody who was probably more intelligent than me figured out something called the reverse shoulder replacement, where the ball is on the socket side and the socket's on the ball side. So if you look at this muscle here, because the rotator cuff isn't functioning, it puts increased tension on the deltoid muscle and can significantly improve function. This is basically what that would look like. And this is one of the operations that I'd say has been a total game changer. So there's tons of studies to show how much better the results and outcomes are, but this is one that has high level evidence and really has solved a problem that we did not have a good solution for. Some of the things that we're getting better at as well, you know, obviously as a surgeon, I like talking about the surgical stuff. It's fun, it's exciting, but, you know, having been an orthopedic patient recently, you know, pain management, the ways we take care of people around the time of surgery also make a huge difference. So we're using regional anesthesia better. So numbing people up before surgery or before fracture treatment. We have long-acting, slow-release local anesthetics. And there's also great evidence for something called tranexamic acid, which can be given topically, orally, or an IV to help minimize bleeding during large surgeries, particularly joint replacements. And so transfusions are increasingly less common. So we're getting better at regional anesthesia and pain control. Let's move along to sports medicine. So from the standpoint of sports medicine, so, you know, we've gotten pretty good at ACL surgery. We figured out that young people, we should be using their own tissue. But we've also learned that, you know, we're learning more about the rehab, you know, not particularly not just afterwards, but before, is that getting people ready for surgery is showing better outcomes and a lower risk of re-injury. And that's been a big push in the last couple of years. One of our therapists, Brittany, sent me the slide. I asked her for some of the, you know, really contemporary cutting edge physical therapy things that we're doing for our patients, particularly. You know, when we say sports medicine, we're talking about a lot of soft tissue injuries or arthroscopic procedures, not all in athletes. And so you can see, you know, dry needling, soft tissue mobilization, cupping, blood flow restriction, you know, and these are things that the athletes absolutely love. And we're trying a lot of these things in people with problems that are actually very difficult for surgeons to get better. And so our therapists are really pushing things forward and doing fabulous things. You know, one of the things, not one of these things is going to consistently work, and we may not see those high level randomized trials because these disease processes are significantly different. But certainly if you have problems getting a soft tissue issue better, you really want to see a therapist who's trying some of these techniques. They're also doing a lot of sport specific things. So we'll do running or gait analysis on a treadmill, throwers, golfers, really looking at the biomechanics of the whole kinetic chain. You know, again, I always say surgeons, we're simple creatures. We like a simple problem we can fix with our hands. But lots of times it takes somebody to take a step back and really evaluate the entire cycle to figure out how to get people better. Large rotator cuff tear. So this is another one that can go on to that reverse shoulder replacement. And we identify a large tear that's been neglected, and sometimes people are told they're not fixable. So we're trying to find a solution for that. One of these is called the superior capsular reconstruction. So this is a patch, a donor patch sewed on there where the rotator cuff would be, where it's not repairable. And you can actually sew the cuff into that to connect it. Do not have long-term studies, do not have large randomized trials, but this is a surgery that I've done and I've gotten some fabulous results early on. And it's something that we're trying to do for people that got to live with it talk otherwise. And so I think this is an operation that we need to continue to follow further, but it showed very promising results in people who we didn't have a good solution for. Also, and that's done all arthroscopically as well. So this is another arthroscopic surgery. Somebody whose rotator cuff has failed or the tissue is lousy, there's patches to help augment them. So large rotator cuff repairs have not traditionally done as well as we've liked. And so we are trying to make those stronger, but we need, you know, again, we need to follow these for years to know if we're really doing what we need to do. So what's new for conditions of the spine? So much like an ankle replacement, a disc replacement of the spine, we want to try to preserve motion. And versus, again, like an ankle, traditionally, if you have a really bad level or two, we do fusions for the back or even larger fusions. And that blocks normal motion, which at one level isn't a big deal, but it puts increased stress on the levels above and below. And so disc replacements are becoming increasingly common. And this was, I think, being discussed when I trained, you know, and I'm not that old, I don't think, but this wasn't even, I've never saw even one of these during my training. And so looking at a study on disc replacement, they're showing fairly similar outcomes and complication rates. It's not superior, but it's fairly similar. You know, the big thing we want to know, again, is how this does long term. So, and they, in this study that they did, looking at the midterm results, they basically said that we need, a greater number of higher quality randomized trials to answer this question. So I asked one of my spine partners for, what's contemporary or cutting edge for spine surgery. And he basically said, spine surgery has limited benefits for many patients with back pain. With improved techniques and outcomes research, there's a much better understanding of who will benefit from surgery. And our goal, is to always optimize non-operative management. And so I think lost in a lot of the stuff I already talked about is sometimes innovation tells us who isn't a good candidate, not just for spine surgery, but just in general. And so I've told patients before is that if I do an operation that doesn't help you, it's like taking your car to a mechanic. It hurts more, but there's a significant time, energy, and potentially finances involved, and you may not benefit. So I thought this was a very intelligent way to look at innovation and decision making. For the treatment of hand and wrist problems, so I think this is a little bit of a game changer. So this is something called Xiaflex. So this disease is called Dupuytren's disease. Patients get cords in their hand where their fingers get stuck down, and releasing these surgically and removing them can be a tedious operation. The nerves can get wrapped around them, and it really is a very challenging, difficult operation. This is an injection that could help help release that tissue and get the fingers straight. And there are some studies that really show that this is quickly becoming a game changer. But we're also learning more about what dosage do you use, how often can you do it, what are the risks, and so this is still evolving, but something that I think has been very cool to watch. Not something I do, but one of my partners does. Also, one of the really contemporary things in hand, wrist, or upper extremity surgery, and sometimes in foot and ankle is wide awake surgery. So that regional anesthesia we talked about keeps getting better, and so having a patient come in, no anesthesia, you don't need an extensive workup ahead of time, no sedation, can resume activities quickly, and is a much it can be much cheaper for both the patient and the hospital, is something that's becoming increasingly popular, and I think that's only going to continue. Fracture treatment. So this is something that I used a little bit when I was a resident. Anybody who did orthopedics that's older have seen these. These are basically bending irons to help. We basically would bend plates to fit specific bones. And so, you'd get a tricky fracture and you'd have to, bend these, stainless steel or titanium plates. And so this is a pretty cool thing that is actually, it just happens to be in Cleveland, is the Heyman Todd collection. So Heyman in 1893 was a professor at Western Reserve University who was in charge of anatomy, and he created a collection of, basically, bones, cadavers. And later one of his students worked for them and would get unclaimed bodies from the county morgue. And they actually have, and this sounds a little creepy, but what we do, we think this stuff's pretty cool. They actually have over 3,100 different bones there. And the reason I bring that up is because, that's something that companies use to help make plates fit better. So when I showed you those bending irons, when we do fracture surgery now, we have these titanium plates, and you'll have a tray. So I alluded to being an orthopedic patient recently. I recently broke my clavicle and have a couple of these little plates on there, and this is something that's made our surgeries much easier because anatomy can be variable, and I can open a tray and there'll be 7 or 8 to 12 different plates for each side, left and right, in different screw configurations, and that is made life much, much easier, and it's been better for both physicians and patients. And this is just an example of an elbow. We have these really nice pre-contoured plates. We also are using the locking screws. So this is a screw that the threads actually lock it to the plate. And so this is something that's very useful in people who don't have good bones. So if somebody has a bad fracture with significant osteoporosis, we have much better equipment to help it stay together to get people better quicker. We also have a lot of biological augments to help help the fractures heal. And this is an example of some of them here. Some of the same, augments. So people who have recurrent stress fractures, we try to rest them that don't heal. You can actually inject calcium phosphate cement in them, which we've done for compression fractures in the back. We're trying that in other joints now. This is not something that we have good long-term follow-up on, but it has been, again, attempted a solution for a problem we don't have an easy answer. Soft tissue injuries. So I already mentioned some of the physical therapy. and the treatments that are being done there. There was that whole list. This is something called 10X. So with an ultrasound machine, you can evaluate a diseased or unhealthy tendon. And the idea is that this small device can help remove some of the unhealthy tendon. This is usually an office-based thing where they numb up the skin a little bit and just make a little, very small incision to do it and use an ultrasound. This is not something I do, but some of our non-surgical sports medicine doctors do. This is something that does not have large, high quality studies yet, but I think this is an area that has been understudied and undertreated. And anybody who has had recurrent tendonitis, surgery is not always a quick or easy recovery. And so this is trying to fill that space between injections, therapy, anti-inflammatories, and surgical intervention. Platelet-rich plasma injection, so PRP. So this is something that, the first few times I saw it was in professional athletes trying to get tendons and other soft tissue injuries to heal better. We basically spin down the blood. So you do phlebotomy, you spin it down or centrifuge it, and you remove the platelet layer, which has basically growth factors that can help decrease inflammation and promote healing. This is something now that, I see people advertising for hair regrowth. They're using it for wrinkles. It's always, I think everything finds its way into the cosmetic space eventually. But basically, this is something that I love the idea of it, but the large studies really have not shown consistently good results. So this isn't something that I do regularly, but we're continuing to try different formulations, and maybe people need quicker therapy afterwards. And so I think the science is there. The studies don't quite support it yet. So I think we do need to learn a little bit more, but I think it's something that can be increasingly useful in orthopedics down the road. Stem cells. So the idea of a stem cell is that it's self-renewing and self-differentiating. Self-renewing, meaning that the body can make more, and self-differentiating, meaning it can become different things. So when we talk about regenerative medicine or stem cells, this is a hot topic. And I have patients ask me about this all the time. And so I think stem cells in some of the cell therapy techniques have skipped ahead. So that early slide I showed where we went from, laboratory studies to animal, small human trials to large trials, some of the stem cell therapies went from laboratory to being done in patients, and they skipped the steps in between. And so if you look at some of the tissue that's used for stem cells, either adipose tissue or bone marrow, only a very small percentage would meet those requirements. So these actually should be purified in the lab and expanded. So the term stem cells is used very broadly. We need to define what they actually are and how to use them. And I had a colleague of mine who is an orthopedic surgeon who had a joint replacement. I overheard a conversation where he told the patient that he doesn't inject them because he doesn't have good proof, and he can certainly afford them, but he didn't have them done before his surgeries because there was no proof that they worked. And it was a very direct approach that I think hammered home the point that I think for a lot of people, for things that aren't covered by insurance, we want to see large studies if people are going to spend their hard-earned money. But this is something that I think most doctors love the idea of. So small cartilage defects, nerve injuries, soft tissue injuries. I think this is an area we should continue to research, and we should continue to try to find solutions for the problems we don't have good answers to, but they're not there yet. And this is just an example of a patient that I did knee replacements on. And if you look at a badly degenerative joint, so not a small problem like a tendonitis or something, the leg is no longer straight. So it's an alignment issue. It's a mechanical issue. There's a lack of motion from the bone spurs and the physical blockade. So I've had people with x-rays that were this bad or worse, ask if injecting some stem cells in the knee will help. And it's just not going to solve, a complex mechanical problem. And so I think we have to be, realistic with what it can do for late stage treatments. And so I always tell people too, is that, you really want to choose your provider, not your treatment. And so try to find people you like and trust that have a good reputation in your community. So along the lines of that, so this is our group, Center for Orthopedics. It was mentioned. We work for UH, and I'm new. Dr. Badinsky on the bottom left is also new. So this is the group here. And when I say choose your provider, part of the reason I joined this group was because I have such a high opinion of all of these physicians, and any one of them can take care of myself or my family. So I tried to move through a huge topic as quickly as I could in 30 minutes, which I think I did, because I was told by Rich and Kelly that there's often a lot of questions afterwards and we need to leave time for that. So as I mentioned, any one of those topics we could talk about for an hour or 2 days, depending on your knowledge base. But the big idea was to kind of show how we evaluate innovation and technology and to hit on some different topics so it may apply to more people that are on this webinar. So I'm going to open it up to questions now. Thank you guys very much for your time.
Thanks a lot, Dr. McCoy. That was just a fantastic presentation covering a lot of different subjects to our participants. My name is Rich. I'm with the Marketing and Communications team. I want to thank Kelly stepping in while I was going through technical difficulties. So we did have some questions that were pre-submitted, and I'll begin to share those with you now. The first one is a bit lengthy, and it comes from John. He says, please discuss the usual sequence of treatments for knee arthritis in a 72-year-old person. And then he also provided some additional background. His diagnosis is arthritis in each knee. He received a steroid injection in one knee 16 months ago for severe pain and has been taking meloxicam, 7.5 milligrams a day since then, which has allowed him to stand or walk for up to 1 hour continuously without pain. What would the normally prescribed next step be after the above treatment becomes inadequate in regards to severe pain returning?
Sure, that's a good question. And so I think that what you started with is common for most of us, which is, oral medications and cortisone injections. Once you get past that, things we know help, low impact aerobic activities. So the whole, you have some arthritis, don't do too much, don't use it, I think is quickly being disproven. So we actually want people to be active. So low impact activities, biking, swimming, elliptical, have been shown to decrease pain scores and improve function. But I always tell my patients, sometimes you could overdo it and you'll pay the price. As you get into the next level of treatments, there's things like gel injections, various braces, and a lot of those are sort of tailored to each patient. Some will work better for others. And so lots of times evaluating, the size and the shape of the leg, is there fluid in the knee, is there tenderness over the bone, can help with the next steps. And so I think that once you get past where you're at, John, it's sort of different for each patient. And the reason is we're running out of consistently easy things. And that's the honest truth. So, but I think that with, an examination and some x-rays, somebody could help at least try some additional things for you.
Great, thank you. The next question comes from Linda, and it's probably in the area of a lot of those miracle drugs that are advertised out there that are going to take your joint pain away. Her question is, I've seen ads that a gel can help knees to avoid replacement. I've had total hip replacement and knee replacement surgery. I've had the unfortunate experience of having thigh/groin pain for almost 10 years since the surgery. So she has two questions, and I'll ask the first. One, should there be any discussion regarding a revision surgery?
Sure. Now, that's obviously a difficult question. So you mentioned the gel injections briefly. I could print you up an article that shows that they work well, and I could print you up an article that says they don't work well. And I think for both patients and doctors, a study that shows that it is not consistent amongst all of them can be difficult. So I'll often tell people with those, if insurance will cover them, it can be worth trying. Painful joint replacements, if there's a reason for it, can be revised. There are a percentage of people, and it's higher with knees and hips, that always have a little bit of pain. And that's where I think just looking at survivorship is one thing. But if we look at a knee replacement, about 20% of people with a knee still have some pain. And I think that, that's where I think some of the robotic technologies, it gets better. If we start doing things right, just getting the rotation absolutely perfect, balancing the tissue a little bit better, I think we can bring those numbers down. The problem is revision surgeries carry a high complication rate. They're really, really difficult. And so it always is an option, but you really want to have a reason for the pain. Now, admittedly, I don't do revision surgery for the most part. So there are a few people that do it and do it well. Dr. Popa in our group is not afraid of those surgeries. And so I think that's definitely a patient-specific kind of conversation. But if it's impacting your activity significantly, I think that's a conversation you deserve to have.
Great, thank you. And the second part of the question is she's asking about hip resurfacing versus total hip replacement. And she notes, I wouldn't be surprised if the other hip slash knee might need replacement and or resurfacing in the near future. I do not want to go
Yeah,
through
so
total, I'm sorry, I do not want to go through total replacement if there is a chance that pain would result on that side as well.
yeah, so I think that would really just depend on the imaging. So earlier in a disease process, that's when the other things work well. You know, that we use the term bone on bone, but a badly arthritic joint, that's when the smaller things don't help as well. So that's something that, you know, the revision situation is complicated, but will smaller things help? I think just somebody looking at the x-rays could answer that question pretty easily.
Great, thank you. Next question. If you have any suggestions for pain management or further treatment for the thigh slash groin pain, I would be happy to learn about this. I underwent 6 months of intense physical therapy, both water and land, and acupuncture. Hoping to hear that there might be treatment available, as I am reading that more and more people are experiencing the same.
Sure. So groin and thigh pain usually comes from the hip joint, usually. And so, you know, working with therapy is not a bad way to start, but that's another one too, that I think getting some x-rays, and if there's not much arthritis, then there's probably a pretty good prognosis. If the hip is arthritic, then sometimes too an image guided injection can help. It won't be curative, but I've had people that, you know, pop in twice a year. We have Dr. Badinsky and Dr. Sandu can do ultrasound guided injections in our group, and they can feel better for quite some time. But you got to get to the usually hip and your groin and thigh pain is coming from the hip joint. In a younger, more active patient, that could be a labral tear. So if x-rays are normal, then you go down the role of getting an MRI, particularly with therapy being done. And so it just would depend on how healthy the joint is and the anatomy, you know, define the enemy.
Great, thank you. This next question is two-parter. It comes from Sandy. First part of her question, and I know you have addressed this a little bit. What changes have been made to knee replacement surgery in the last 10 years that would improve the overall success and make recovery easier?
That's a great question. So so less blood loss, you know, with the tranexamic acid. I cannot remember the last time a patient of mine got a blood transfusion. It just doesn't happen for any of us anymore. So we have medicine to minimize bleeding. We inject numbing medicine in a multimodal sort of pain injection around the lining of the joint at the end of surgery to help with pain. Now, I'm not saying it's pain-free, but it's definitely better than it was 10 years ago. And the anesthesia is doing better blocks, but they're also preserving muscle tone afterwards to get people up and moving right away. From an implant standpoint, the spacers are lasting longer. We have 1 millimeter size increments now. And so it's much easier to balance and fit. And also, some of the implants also remove less bone. God forbid it needs to be removed. The patient-specific knee replacement and the robotic ones can also, you know, make it an even more precise operation. And again, maybe anyone who's doing lots of them doesn't necessarily have to do that, but I think that can help lower that number of people who have residual pain. I think the rehab is probably a little bit better. And I think those are probably the big ones.
Great, thank you. And then the second part of the question is, what can be done about post-operative scar tissue that causes pain and greatly limits mobility, no matter how great the x-ray looks?
Sure, yeah, no. If somebody has a knee replacement that's stiff afterwards, it can absolutely be scar tissue, or sometimes the technique that was done, you know, sometimes that the knee, there could be bone spurs in the back or other things that maybe weren't addressed completely or were difficult to address. But if it is truly just scar tissue, there's a quick window after surgery of a couple months where if you don't break it up, it gets very difficult. Going in later with a scope and releasing scar tissue is something that can be done. We're always very careful afterwards with any intervention because there's a risk of surgery, of infection, sorry. But for somebody who is, you know, over, you know, 6 to 9 months out, if they have a fairly stiff knee, difficulty riding a bike, et cetera, then there are some indications to go in and try to remove scar tissue arthroscopically.
Thank you. Next question. Does acupuncture solve or alleviate arthritis in knee or shoulder joints?
That's a good question. So for common problems like arthritis, we have an academy called the American Academy of Orthopedic Surgery that gives us clinical practice guidelines, and they update them every few years. They get a whole panel of people to put them together. For arthritis, the recommendation for acupuncture was inconclusive. So again, the bottom of the pyramid is me, expert opinion. There's somebody that went through all the studies, all the research, and pulled them, and those people don't have enough information to give a strong recommendation on it. So again, that's a high level of we don't know, basically.
Okay, thank you. This next question is from Lita. Is robotic surgery an option when a repair is needed for a patient who has had total knee replacement?
I'm not sure what you mean by repair. Um, robotic surgery can be used for almost any knee replacement. If somebody needs to have something redone or revised, if that's what's meant by repair, not really. But they're actually working with the robot now to help with revisions or to help remove implants for revisions or redo surgeries. So, but it can be used for almost any normal knee replacement.
Thank you. Next question. I am a 74-year-old type 1 diabetic. I frequently have UTIs several a year. My hip is bone on bone, but the doctors have advised against hip replacement because of the risk of infection. Is there a way to treat an infection in the prosthetic without removal?
Yeah, absolutely. So you probably need to find an infectious disease doctor who's comfortable with orthopedics. There's some that help us regularly, and it needs a coordination between a surgeon and an infectious disease doctor, urologist, to probably have you on antibiotics around the time of surgery to make sure that the infection is controlled. And so it's a situation that we've encountered before. Because, for example, if somebody has recurrent or chronic UTIs and falls and breaks their hip, we won't not fix the hip. We still do it, and we just we keep them on medication to help prevent it. So the acknowledgement that the risk is going to be a little higher is there, but it does sound to me, with limited information, like something that could still be accomplished.
Great, thank you. Next question comes from Barb. Is robotic surgery less costly than traditionally performed surgery in terms of joint replacement?
Yeah, that's a good question. So they have articles about financial cost analysis that, whether it's robotic surgery or anything else, they're just fascinating because there's all these variables. So if you look at cost, there's cost for the patient, cost for the hospital. But basically the short answer is that it is a little bit more expensive because there's some imaging ahead of time. And in general, the surgeries can take a little bit longer. But if you make the argument that we're going to eliminate outliers, so people, you putting an implant in that's not perfectly straight, is it if you take somebody whose implant doesn't work or has to be redone and all the costs associated with that, and we can get people moving quicker and feeling a little bit better, it probably may end up saving us money. So, but for the most part, if it's something that's covered, if everything's covered by insurance, and so if somebody, say, has a deductible, if you have a big surgery, you're paying your deductible either way. So it shouldn't be a major cost difference to the patient, but it can be a little bit more expensive.
Thank you. This question is from Erica. My doctor cleaned up my knee, but I have not seen a lot of improvement. I cannot walk like I was able to in terms of exercising. Why didn't he just do a knee replacement?
Well, that's a good question. So number one, we've all done that. One is if you look at a knee that has some wear and tear in it, often we see meniscal tears, cartilage flaps that are hanging, things that we can easily clean up and make it look better. But I tell patients a lot that I can make things look better, but you may not feel better. And so younger, more active people, we worry about how long a knee replacement will last or a hip replacement. So I've tried, to clean up knees in people who are younger, who probably would be better off with bigger surgery, because we want to try to delay having to have it redone or having to have it redone twice, which would be a difficult situation. And so I think that I'm having increasing conversations with people where I tell them, and people often want the other way, will say, hey, I would love to have a scope and a quick recovery and easy surgery. And I just tell them quite honestly, it's something we can do, but I don't think will help you much. And I think that generally the physician is trying to do less, but yeah, we all are guilty of hoping that less will work. And when it's not effective, then you've already identified that maybe something bigger will be more useful.
Thank you. Next question comes from Don. Says, hello, I've had metal on hip 17 years ago and I need both knees replaced. Should I have the hip looked at before I proceed with the knee replacements?
Yeah, I mean, so if somebody saw me for a knee replacement and had other joints that they wanted checked out, a quick x-ray would kind of show how it's doing, in, a quick exam. So that would be something that doesn't need an extensive workup, and evaluating a joint replacement to see how well it's functioning. If there's any signs of loosening, you don't even necessarily have to see the doctor that did it. Most of us can look at it and say, oh, hey, it actually still looks pretty good. So it's not a necessity to do that ahead of time. But I do think it can help, get an overall picture, because hip pain can sometimes radiate down the thigh. And so if the hip doesn't look great, some of the pain between the knee and the hip may not all be the knee. And so if you have a knee replacement, you go, I still got some pain up above the knee. It doesn't look good later to realize the hip was the problem.
So this next question is probably a little more for the Spine Institute or a spine surgeon. I'll share it with you. Is disc replacement being used for arthritic joints in the neck? Are there other options than fusion?
Yeah, so a disc replacement or an anterior cervical discectomy or fusion, and they're actually have something called a laminoplasty, where they actually just create more space in the back too. So there's a few different operations they're doing, but I already kind of disclosed that I have very limited experience with disc replacement. But I think that's quickly where things are going.
Yeah, and I am aware that that procedure is being done at UH St. John Medical Center as well by one of the surgeons out there.
Yeah, so my partner, Dr. Berkowitz, would be the guy to talk to about that.
Next question comes from Teresa. I'm over 2 years post ball and stem removal right hip due to strep B septus. My femur keeps migrating due to no spacer implanted at time of removal. This is causing pain. I also have an over 3-inch difference in leg length since then. This was done at University Hospitals downtown, March 2019. No one wants to reimplant the joint. What options do I have?
Well, number one, that's not a good situation. And saying you have pain, I completely understand that. And functionally, that's difficult. So number one, I'm sorry you're going through that. Like, very genuinely, that's a tough situation. And again, I don't do regular hip replacements. I certainly don't do revision hip replacements, but I can speak to you about some of the principles. Is that the infection has to be eradicated. And so that's something that with laboratory studies, tissue biopsies, or cultures can help determine that. Never 100%. And then depending on, what the bone stock looks like, which is left after those surgeries, that's something that there are a handful of doctors in every city that do the really, really tough surgeries. And again, one of the reasons I don't think I'd be able to sleep at night. I run a little anxious as it is. And so I think that's something you just have to find somebody who's willing to do the harder surgery. If the infection is still lingering, then it may be difficult to do. But those are things that are usually done at tertiary hospitals. And I would just keep looking for opinions until you find somebody who can help you, if they can help you.
Thank you. Next question. Can you talk about partial knee replacement versus full knee replacement? What are the average recovery periods, longevity? Will it need to be redone in 15 years? And decision factors to decide which is most appropriate. Also,
Sure.
Is it true you won't be able to kneel after either?
That's the great. So number one, I love that, because the robotic surgery, and I didn't want to make the talk just about something I do, because I think, again, it doesn't apply to everybody, but I love partial knee replacements. I love them. And the reason is the knee feels more natural, and it's a quicker and easier recovery. And people just, the sensation of this knee is not mine, or the joint is not mine, is common after total joint replacements. We just don't see that as much with the partial replacements. And again, I think because they were kind of finicky, people just sort of, they can be a little, not, I don't want to say difficult, but they're definitely harder than a normal replacement. And so I think that's where, again, for me, if you're going to have a partial, it should be done robotically. I really do believe that. But from the standpoint of longevity, it's a little tricky. They should last a very long time. But what can happen, number one, is if the knee is bad in several compartments, so there's 3 areas that have cartilage in the knee, the inside, the outside, and the front. If 2 or 3 areas are bad, people often want partials. And I tell them, you don't want incomplete relief of pain. You should do more. So, maybe 30% of people qualify for that, give or take. But if the partial replacement is done, on the inside or outside, that is somebody who will be more likely to be able to kneel because the kneecap can be left alone. So I do have patients with partials that kneel, but I think if you're kneeling for work, gardening, going to church, and it's a regular and important thing for you, the acknowledgement that with any major knee surgery, it may be uncomfortable, I think is important, but definitely easier with a partial than a full. And then recovery time, recovery time is so variable between different people based on their pain thresholds. But I saw, again, a patient today was just under 2 weeks out from a partial replacement who walked into my office. She's in her 70s, walked into my office with no cane, and she had pants on. I honestly, watching her walk, had trouble telling which side. There was very little favoring of the knee. And I almost wanted to just say, hey, can I take a video for my talk tonight? But, I put this together at the last minute. The last thing I need to do was add more. But she was at 2 weeks with minimal pain, just pain at night. That's atypical. Usually it's worse than that. But the last patient I saw before her earlier this week works on his feet part of the day seated. He's 5 weeks. He's back at work. He's, off the pain meds after 2 weeks. And so I saw 2 in a 2-day period that are just doing fabulous. That's not always the case, but I tell people with a full joint replacement, plan on not liking your doctor for 2 months. I think for a partial, you'll plan on not liking your doctor for 6 weeks. So, but that's, again, people's own pain threshold and how much swelling there is can make a huge difference.
Thank you. The next question comes from Thomas. He just made a statement. He said, after 15 months of knee replacement, there is still swelling and stiffness. So I think he's probably looking for next steps.
Yeah. So so the best predictor of motion after surgery is motion before surgery. So if somebody has really, really difficult motion, really, really bad arthritis, some stiffness will always be there. And that's something that should be identified and discussed ahead of time. The scar tissue buildup, again, is something that was discussed before. Early on, you work hard on scar tissue. You can actually bend the knee to break up the scar tissue, but that's only usually effective in the first few months. And so evaluating to make sure there isn't a low-grade infection, but also then again, considering, evaluating if there is extensive scar tissue, if scoping it and removing that could be helpful, is something you can do. But that's a tricky problem.
Thank you. Next question. If someone is in need of surgery using the metal plates, disc, joints, etc., and has a dermatologically confirmed allergy to cobalt, are there any other options, and would such an allergy be manifested internally?
Yeah, absolutely. It could be. So that's a good question. So we do deal with metal allergies. We can actually send off some blood work that looks at common orthopedic materials. So some testing we do ahead of time to help determine which materials are okay. But for somebody who has an issue with nickel or cobalt, we use various different metals. There's something, we can use titanium, but there's also a metal called oxinium that we use for certain joint replacements. So yes, it can absolutely be done. And I would recommend having some blood work done to help confirm, because sometimes there's other metals that people could be sensitive to, but it just requires a little bit of planning in advance.
Great. This next question is from Josh. If I were to have joint replacement done robotically, where is that done at UH?
So I'm working on the west side of town, and we're doing it at Elyria Hospital. Rich, you may know better than I do. I don't know if we have that ability in other locations.
At this moment, the robotic technology is located at UH Elyria Medical Center. You're absolutely correct. That's the only location.
Okay. And I tell people too is that like for a partial knee, I've had people, I just operated on a guy from Pennsylvania, and I told him is that, hey, you get in your car to drive to the Apple store to get your phone fixed. You'll probably only be in the hospital for one night. Is that if that's something that's worth it, you just gotta drive a little bit. So and that's a place that we're doing lots and lots of them right now. So
great. Okay, this is actually the last question. It's from Almas. What is the reason for not doing both knee replacement surgery at the same time? Or actually, I think what they meant is for not doing both knee replacements at the same time.
Sure. That's a good question. And so you can do both knee replacements at the same time. I think that for people with medical issues who are a little older, I think there's a higher risk of medical complications or problems, although there's some conflicting studies on that if we get into the science of it. But just from a personal standpoint, if one of my family members was having it done, I think that it just tends to be a lot of surgery. With one done, you can go home the next day. Two done, you may need a rehab stay. There's a high risk for falls, and if you really work hard on that range of motion and the therapy, you do a 45-minute hour session, and you get done, and then you got to go do the other side. It just ends up being a really difficult recovery. But for young, and I don't mean young like 25. We don't do joint replacements on really young people, but for somebody who's active and healthy, who wants to minimize time off of work, if it's somebody self-employed and it's not I want it done quick because it's more convenient doing both. But if there really are strong reasons to do it, it's something that I do. But again, it's everybody should be treated like family. If somebody has, some heart issues, diabetes, et cetera, and it's really not safe to do additional surgery, and you wouldn't recommend it for a family member, you just unfortunately sometimes have to tell people that it's not the safest thing for them.
Okay. We did have one more question come in, and this will be the last question. It comes from Laura. I had ankle surgery over 10 years ago after a break. The hardware was removed a year later. Now I have osteoarthritis. Do I have any options?
Yes, but arthritis treatment, whether it's the ankle, knee, hip, et cetera, you start with small things. Anti-inflammatory medicines. Again, sometimes an injection, a cortisone shot. So say that, Laura, you really love doing stuff outside in the summer. Sometimes a cortisone injection can really help you enjoy this beautiful Cleveland weather where it snows in April. But it won't necessarily change the disease process, but could provide you some temporary relief. As arthritis gets worse, that's when we get into the bigger things, like fusions or replacements. And so I tell people for arthritis, we tend to do small things or big things. There's not a lot in between. But again, an X-ray to see how much arthritis can be useful there, but it's not a fun problem, obviously.
Dr. McCoy, thank you so much for your time this evening and sharing all this information, answering all these great questions we received. To our audience, thank you all so much for registering and joining us tonight. Again, just tremendous involvement from everyone. A couple of reminders for the audience. You will be receiving an email within 1 to 2 weeks thanking you for your participation, but more importantly, you will have a link to Dr. McCoy's presentation, so you'll be able to view the entire presentation as well as hear the question and answer session. So for any of you that are interested in making an appointment with Dr. McCoy, please call 440-435-7640. Dr. McCoy sees patients in Westlake at UH Sheffield Health Center, which is the home to the Center for Orthopedics. And he also sees patients at the UH North Ridgeville Health Center. Now, if you're happen to be listening out in Ashtabula and you'd like an appointment a little closer to home, you can call 216-243-2028. But again, for an appointment with Dr. McCoy, it's 440-435-7640. If you need additional information, feel free to go to uhhospitals.org/ortho. Any information you're looking for orthopedics, conditions, and treatments, you'll find there. So again, this concludes tonight's session. We want to thank you so much for attending, and we hope that you'll join us for upcoming virtual health talks. Have a great evening.
Thank you, guys.